Hi everyone, Melanie Grant here. This video is for my Health Information Technology Reimbursement Methodologies course, where we're talking about our new Medicare SNF reimbursement purchasing program. Now, with the SNF services payment plan, there's a lot of details. So we're going to take it one step at a time and look over some of the information you'll find in your reading today. We're referencing the 7th edition of the Reimbursement Methodologies as published by AHIMA, and I'll be sharing that PowerPoint with you here. So give me just a moment and we'll start that PowerPoint. Okay, so Principles of Healthcare Reimbursement and Revenue Cycle Management. This is Chapter 6, which focuses on Medicare's Skilled Nursing Facility Service Payment System. That is one large statement there. So for easier references, we often refer to skilled nursing facilities as SNF or SNF. We'll be looking at the SNF PS or payment system as defined by Medicare. Now, of course, we want to be able to say what is a nursing facility specifically so we know when to apply this. But we also want to look at how the patient's needs drive the payment for what's considered a variable per diem adjustment and how they look at value-based purchasing. We learned already about what value-based purchasing is, what payments are, where we identify services specifically on how good a facility or a provider is doing in order to say how much money they should get. So we're going to go ahead and take a look at all of those. But first, what is a SNF? Well, a lot of times, most people don't think of SNFs in terms of what they actually are. They think of nursing homes or retirement homes. But in fact, a nursing or retirement home is not considered part of a SNF. Specifically, a SNF is something like a rehab, where patients are admitted specifically from a hospital for short-term needs. These are things like they broke their leg and had a major surgery, help I've fallen, I can't get up, or other cognitive issues which need to have new treatment plans, new ways of life that are identified to the patient or the patient's family for ongoing care. Now, our SNF sites are about 95% of them have freestanding facilities. That just means that they're not associated with other facilities like large medical groups. They may at times, though, be part of that. So they could be part of a hospital unit or even what's called a swing bed, which is where it's a SNF, but it's also an inpatient. And the only person that really knows are the doctors that are treating the patient. And of course, those of us doing the billing. So it's very common for patients to really not know where they're at. But that's okay. That's why we're here. The first thing that we talk about when we say what is a SNF is what kind of services does a SNF actually provide? So the term ADL or activities of daily living are constantly discussed in SNF facilities as one of their basic concepts. It's basically things that a person should be able to do on their own, but due to life circumstances or disabilities they were born with, or sometimes injuries that they've had, and sometimes just getting older, they need some help. The ADLs are going to be measured by the facility and the SNF providers to determine exactly how much dependency they need. These are things like their personal care services, helping them with medications, knowing when to take them. If they have memory problems or cognitive care, they may need a lot more care on personal care than most people would. But SNFs also look at rehab. And so we're not talking rehab necessarily from medication use or alcohol, but rehab as in rehabilitation of getting your body back to its normal function or its new normal after things like an injury or a major event that's happened that needs physical or occupational therapy, speech therapy, or sometimes a little bit of everything. So this is called a PDPM. It's a patient-driven payment model. You have so many abbreviations that this one is one of those where you just want to remember that when we say PDPM, we're saying it's driven by the needs of the patient. Per diem means that we're looking at each need in determining the full cost of the reimbursement. And we're going to look at residents or patients, which are called residents because they reside there, they live there for a short term. We look at each of the residents based off of their needs and several factors that we're going to look at here. Used to be, SNFs were just paid one basic payment, and it was determined that not everybody has the same needs or care. So after 29, Medicare came out with the PDPM in order to look at each patient as a whole. This starts by looking at reports. So there's three main ones that kind of have, top guns in this area: your MDS or minimum data sets, care area assessments, and RAI, which is your residential assessment instruments. All of these are reports that the SNF providers are entering into the system that pull data that's been aggregated into other reports to give them just kind of like this power number, kind of like doing numerology in a lot of ways, except with the patient's care needs. Wrong way. The first thing that they look at are several components that affect the patient's care. So the nursing staff themselves, any non-therapeutical ancillary services, so you have like a little vaccine picture there, what's called a non-case mix. So you'll remember that case mix is talking about the types of patients that we have in a specific facility. And this is specifically looking at what's not included in that, more in terms of care for the patient themselves. Then, of course, your therapies. You have the physical therapy, your occupational therapy, and your speech language pathology. Once all of those are put in together, they then make adjustments to the PDPM based off of certain needs and things that they've identified from the facility itself. So an adjustment, for example, might be the case mix group that the facility falls under. If they're a larger group that takes very complicated services, they'll get a higher case mix. And so that adjustment gets added in. Don't worry, we're going to do lots of math together towards the end. And by a lot of math, just a couple. But if you have a facility that has relatively easy care, you might also see an adjustment on a CMG for a facility that's lower. It all depends on the types of services that are usually provided. Keep in mind though, it's still patient oriented. So one of the big components in this is looking at physical therapy and occupational therapy to determine really just how much assessment does the patient need. We're going to look at this table here and we see there's two different options. You have clinical reasons for stays and functional stays. And the clinical reasons, these are going to be things like how bad off are they and how much service do they need? Whereas the functional stay pulls information from that MDS report that I mentioned earlier. It's basically saying how functional are they? How well can they do basic activities of daily living? And so these are two different measurements that are put into your PDPM, which is really just, they're called components. And so they're just going to adjust in that math to tell us how much this patient is needing per day for their skilled nursing facility services. Now, if that's not confusing enough, they also have what's called a variable day or a changeable day amount. I know, it can get really confusing, but keep in mind that as a patient grows into their new normal or as they start to heal, they're not going to need all the same services at the end of their stay that they needed in the beginning of their stay. Some examples, for instance, a patient who we had earlier that fell and broke their hip, they're going to have a lot more needs for physical therapy and even occupational therapy right after having fallen. But once they start getting used to the new normal, they're not going to need as much services. They'll also be familiar with how to take care of themselves because they're probably wanting to get out of there and go back to normal. So we have those adjustments. And we also look at, sorry, I went too fast here. So we have those variable adjustments that are going to look at the patient's needs on what's called a per diem amount. So we do have a nifty little table we can look at for that. So table 6.2, which I'll be sharing here. Ooh, that's not table 6.2. The table 6.2 in our book actually gives us an example of what that looks like. So a patient here on days 1 through 2 may have an adjustment factor of 1, but you see as it goes up more and more dates, those adjustment factors go down. Remember, we just looked at what an adjustment factor is, and it's based off of more versus less needs. So the longer they stay there, the less needs that they're going to have, and eventually the cost per day just goes down. So we're dealing in what's called units or numbers. Going back to our PowerPoint, our next area that we look at as we continue with this is our speech language and pathology. So we've looked at physical therapy and how it's addressed along with occupational therapy. But what about speech language? And what are the reasons for speech language? So you have different categories. The first one, like, are we looking at damage to the patient that's permanent? The second, are we looking at specific comorbidities, like patients with uncontrolled diabetes that are causing neurological damage? Cognitive impairments, are they able to really comprehend what we're asking them to understand? And then, of course, physical issues such as not being able to swallow or having to have a mechanically altered diet. Those are all going to increase the need for their services based off of what they have. We also have additional considerations to the per diem rate by looking at things that might increase or decrease cost. These are all considerations that are found on those NDS reports. The ones we mentioned earlier that we talk about functional scores, but also some of the things that we look at throughout the visit, like what clinical conditions do they have, or did they become really depressed while they were here? Because not everybody likes to be in a skilled nursing facility. Additional components that go into the total payment on the per diem includes high rates for conditions that will affect certain services like HIV and AIDS. In fact, we have an 18% increase on payment just based off of the patient having that as a diagnosis. Why, you might ask, would a patient with HIV or AIDS have higher rates for reimbursement if they're there for a hip replacement? Well, if they do have AIDS, or even HIV, which can lead to AIDS, they're at a much higher risk for infection. So they're going to need additional things like medications. Providers may be using additional precautions in their PPE and keeping the patient under isolation. All those things will increase in order to provide the best possible care to every single patient. And just like DRGs, we measure that based off of the ICD-10 CM code being listed and available on the medical chart itself. So the code is B20, which is the HIV diagnosis for AIDS. And that's going to give additional points to the total score that determines the total cost. So when we look at that, we'll see kind of how that breaks down. But just know that these are additional what's called NTA components or non-therapy ancillary components, meaning that it's not what they're here for, but they absolutely need care for these reasons. At that point, we're going to determine the total of the component, and it's variable on a daily basis. We have another table we can look at to see exactly what that looks like. But basically, adjustments for payments days 1 through 3 have a variable amount where there's more services, and so it's going to be higher than throughout the rest of their stay. The next area is the non-case mix component. So I mentioned this earlier, that there's certain things that do affect the patient based off of the types of visits the hospital have. And then there's components that are based off of what's called a non-case mix. And so this is broken by two areas. This component represents the room and board services, so just running the facility, but it doesn't actually look at the patient themselves. So without looking at the type of case mix, they just say, how much does it cost to operate the hospital? Or in this case, the skilled nurse facility. Finally, we take the last area, which is determining what's called a base rate. So this is where it starts to make a little bit more sense, besides actually doing it. We put them together and do the math. Based off of the location, and again, this is not a case mix, but we determine if the facility is in an urban or rural area. With rural areas, keep in mind that there's less tools available, and usually providers have to run multiple hats and they get paid more for being in a rural area than they might in an urban area where they have more state-of-the-art technologies and a lot more staff. For that reason, it actually costs more in a rural area to provide services than it does in an urban area. And so we have this difference here, what's called a base rate that's provided to us from Medicare and tells us exactly how much is the base rate per diem per day that we're going to adjust for those factors. And then we just put it together. We determine the base rate. So again, going back up, we say, are we looking at services for physical and occupational therapy, speech and language pathology, nursing, our NTA, and our non-case mix components. Each one of these with their base rates get added, and then they adjust for geographic factors, the adjustment for case mix, the adjustment for the dates of stay, and the sum of all of those components at the end. Don't worry, this is typically done in the data system for you, even though we say do the math. But we're going to do the math anyways. Let's look at this together. So we have Jose, who is a resident at a community SNF, which is classified as an urban facility, meaning that we're going to get a higher base rate. And we can see the units here in this column of this Excel spreadsheet that we're viewing here, what those urban base rates are. He has a 10-day stay with a clinical category of acute neurological condition. His physical therapy and occupational therapy functional score is 10, and his nursing functional score is 7. So they're going to pull that information into here in order to determine the total scores. There's a moderate cognitive impairment and receives a mechanically altered diet for SLP-related comorbidities of dysphagia, which is, of course, a swallowing disorder. His nursing level and assistance with daily living and general supervision, and he receives 2 restorative nursing services, giving him finally a combined NTA of 7. So all of that's done for us here. We don't have to go and pull this information up, but these would be things we would put directly into a spreadsheet based off of data that we look at to say, what is this equal to? At that point, we can see the wage index adjustment, which is a 1.241 multiplier. This is just an example, but this is something that would be given to us. We would take our urban base rate and our multiplier. We would utilize the case mix group and CMI and the adjustments for those. And finally, determine the total factor of, do we have aids? Is there an additional points given? So you remember we said we had 8 points if they had aids. Here we had none. So each day was 1 unit at the total adjustment amount, which was 110. And so we got that from all of this to give us the component payment here to the right. So for each of the services, we finalized the service at the total component amount based off of the base rate, the wage index information, which reduced it, and then multipliers that were included from various specifics that the patient had themselves. finally coming with the total component for each item. At the bottom here, this is just simply added with the variable rates of days 1 through 3 and 4 through 10 based off of the NTA that we talked about earlier. If that makes about as much sense as mud and it's as clear as mud, good, you're learning. But you'll do some of these practices and you'll see how easy it becomes after working with a couple of these. Our next example here, we have Victoria, who's a resident at Memorial SNF and is classified as a rural facility. She has a 22-day stay with a clinical category of medical management. She has lung cancer receiving radiation therapy, has a PT and OT functional score of 6 with a nursing functional score of 6 as well. Her nursing level is considered serious medical conditions due to radiation therapy, and she also has AIDS and depression. This ends up bringing her NTA comorbidity score up to 9. And so as we look at those differences here, and again, this is going to pull those scores from the nursing documentation and pulling base rates and everything from a list. We pull in the rural base rate of each area and the wage index adjustment rate for her area. We pull any areas that indicate case mix group or index here and make those adjustments based off of that information. We look at the variable days at 3 versus 1 points, and our total amount for each area is calculated to the right. So even though Victoria has a condition with the AIDS and depression, her per diem cost is actually going to be quite a bit less than our previous patient who had more severe conditions. Ultimately, once the per diem rate is determined, we submit to the insurance in hopes for a full reimbursement based off of all of the qualifying factors. But at this point, we're not done. The last thing we have to consider is how well our facility is performing or the facility we're paying for if we're on the insurance side. We've talked about value-based purchasing programs before, so this is the same kind of thing, but for SNF. It determines the performance of the facility based off of the measurements that are identified here, which look at readmissions and preventable readmissions. So basically, they say how many overall readmissions are you receiving and compare that to normal national-wide readmissions for areas similar to yours. And then they say how many of your readmissions were preventable. And looking at reports and information, there's specific diagnoses like having hospital-acquired illnesses or conditions that will trigger for saying this was preventable and they should not have been readmitted, or for certain conditions that they should have been kept longer for. This gives a total performance score, and each facility is able to review the achievement score and an improvement for full payment. The sad thing is if they score low, then Medicare is going to withhold 2% of their payment. It doesn't sound like that's a big deal, but that can be huge for facilities who are talking about large payments in order to pay for all of the services that they're providing. So obviously, as we look at each of these areas, we want to make sure that we have all of our details and ducks in a row. How do we do that as health information management, individuals, or technologists? Well, our first step is making sure the data we collect and enter is accurate and full of the exact detail that's in the documentation. We work with our providers to make sure everything is documented appropriately, as well as our nursing staff and ancillary staff. And we double check our math about 5 different times. And as I mentioned, don't worry, your system will help you. And of course, as you're learning, you should have some sort of management support, or you can find a team of networks out there on the internet ready to work with you with probably the same questions you have. That's all for today. Good luck with your SNF billing, and let me know if you ever have any questions. We'll talk to you soon.